Hi guys, welcome back. I shall now be discussing some image-based questions from hematology with you, starting with the very first one. It says a 16-year-old girl has presented with pallor and hepatosplenomegaly on per abdominal examination, which talks about evidence of hemolytic anemia. Peripheral smear here is shown with the appearance of the patient, and he's asking you what investigations will help in the clinical diagnosis of the patient. Well, first and foremost, when you cast a glance at the peripheral smear, you will notice a pink dot back in the middle of the red blood cell, which tells you that is definitely showing you target cells. And second, you will notice that in the physical appearance of the patient, the malar eminences of this particular case are very, in your face kind of, or having a prominence. And at the same time, you will also notice that the incisor teeth also look relatively prominent. The lip is pulled outwards, and then the nostrils of the child. You see, the nostrils in you and me will be opening inferiorly, but if I zoom it in here, you will notice that the nostrils are present slightly anteriorly. This is what is classically called as chipmunk faces, and therefore on the basis of three informations given in this question, that is going to be organomegaly in the form of hepatosplenomegaly, target cells in peripheral smear and chipmunk faces, my diagnosis of this particular case would be thalassemia. I'm ruling out sickle cell as a possibility because you anyway know that by 3 years of age in sickle cell anemia, there would be autosplenectomy. This patient has presented at about 16 years of age, so unlikely to be a sickle cell, unlikely to be thalassemia major as well. In fact, the way the question is framed, I think clinically speaking, this would be a case of thalassemia intermedia. Now, he's asking you what investigations would help you. So, since in India, beta thalassemia per se is reported quite frequently, so HBB gene sequencing definitely makes sense because the gene involved in beta thalassemia happens to be the HBB gene. High performance liquid chromatography is the investigational choice for any hemoglobinopathy, so makes sense. C says EMA binding, eosin 5 melanimide flow cytometric binding test per se is what you read for diagnosis of hereditary spherocytosis. So this is the odd thing here. And reticulocyte count, yes, because in all hemolytic anemias there will definitely be evidence of reticulocytosis. So option number A, B and D are the correct statements here, which means that option number 3 of this question is correct. You will notice that in the current pattern of the exam, they have made the questions relatively lengthy, and at the same time, because you now have to select multiple correct options, so they can definitely be errors of judgment. So it is not only about accuracy, it is also about speed, because you need to solve these questions in a limited time frame. Moving for the second one for today, he's talking about a 45-year-old construction worker who's having complaints of paresthesias in the hand and feet with weakness of the hands as well. So paresthesias implies sensory, progressive weakness implies motor manifestations, both are present. So whenever you read about, paresthesias per se, what comes to your mind is definitely involvement of nerves, and neuropathies can contribute to weakness also. On examination, there's an absent ankle jerk with a Babinski sign. Now, that's a very surprising information given in this question because absent ankle jerk points to lower motor neuron lesion, whereas Babinski sign would point towards upper motor neuron lesion. You see, in a single question, he's mentioning combination of two present, lower motor and upper motor in a single case. The tone in the extensor leg muscles is increased. That he's probably talking about the spasticity component, and therefore he's asking you what is the possible diagnosis. So what I am gathering from the question at the moment in the first read is that he has given me a hematological presentation, spinal cord presentation, and a combination lower motor and upper motor manifestations occurring simultaneously in a patient. So let's work it out. Option A says lead poisoning. Now you're aware that in lead poisoning per se, there is basophilic stippling of red blood cells. So I will zoom in into the peripheral smear for you, and you will notice that the RBCs look okay, at least from the perspective of not having any basophilic stippling. Because if it's going to be a red blood cell which is going to be having such blue spots like these, then obviously basophilic stippling can be considered. Then, in this particular case, the RBCs look fine. When I say that, a lot of students send me a query saying, sir, what is this blue thing? Well, this is a lymphocyte. The nucleus of this is intensely basophilic. In fact, the nucleus of a lymphocyte is so big that it will occupy most of the space and it will push the cytoplasm towards the periphery. As a result of it, the importance why a pathologist will always look at a lymphocyte and compare it with the size of red blood cells is because if the size of the red blood cells is smaller than a lymphocyte, microcyte, equal normocytic. If it is bigger, macrocytic. In fact, in this case, you will notice some of the red blood cells are actually size-wise looking relatively almost equal to bigger when it comes to comparison with the lymphocyte. So I would like to give a benefit or doubt towards macrocytic anemia being present in this case. Slash it can be normocytic also, because I'm not a trained pathologist. So there's a possibility I'm overreading. Option number A is unlikely to be the answer to this question. Why? Because lead poisoning usually has basophilic stippling of red blood cells, and we usually don't read about any spinal cord involvement per se. So this looks unlikely. B says copper deficiency. We are all, mentally trained to pick up Wilson disease, which is copper excess. He's saying copper deficiency. So may or may not be the answer. Let's read further. Miller-Fisher syndrome. Miller-Fisher syndrome is a variant of Guillain-Barré syndrome where you will read about ophthalmoplegia, areflexia, and ataxia. You see, the main presentation in Miller-Fisher syndrome is third nerve palsy because of the ophthalmoplegia component. But in this MCQ, there is no mention given of any cranial nerve involvement per se. So I'm ruling out option number C also, since no ophthalmoplegia, no third nerve palsy is given. Devick's disease is the older name for neuromyelitis optica. It may be the answer to this question because myelitis, and definitely a MRI spine is given in this case. So it could be myelitis with some extra feature. Now, when you study the literature neuromyelitis optica, I have highlighted that the optica would basically mean there would be optic neuritis, which can contribute to blindness in this case. But per se, if you look at the language of the question, there is no evidence of any optic neuritis or blindness occurring in a patient. So between option number B and D, why am I ruling out option number D is because there is no blindness per se given, and therefore the correct answer for this question on exclusion is copper deficiency. Well, you might ask me, sir, what's going on? Well, what's going on is a combination of macrocytic anemia, and along with that, the MRI is showing a signal of demyelination. So there are two things which are occurring in this case. One is macrocytic anemia, second is demyelination of the spinal cord per se, and the combination of the two is what you read in a disease which is called as subacute combined demyelination of spinal cord. Subacute combined demyelination of spinal cord can also be having demyelination of the nerves. Because of the demyelination of the nerves, that is why in this particular question there is mention of paresthesias, because the nerves are getting involved and nerves getting damaged. So that is why ankle jerk is also absent. So two things in this question are explained by a demyelination of the peripheral nervous system. But at the same time in SSAD, there is also demyelination of the corticospinal pathway, and when corticospinal pathway will be damaged, then Babinski sign will also be seen. I have highlighted in routine lectures that the combination of lower motor and upper motor neuron lesion, especially if you listen to amyotrophic lateral sclerosis, motor neuron disease towards the end in neurology, I have highlighted if you ever get a combination of these two in a single case, either it is motor neuron disease or it is subacute combined demyelination, or it could be Friedreich ataxia. Well, subacute combined demyelination of the spinal cord can also be seen with. This was slightly a difficult question. One of the aspect that I wanted to remember is copper deficiency can actually mimic features of subacute combined demyelination. Now, even if you're not aware of this rare fact, why I am discussing this question is mainly to sensitize you to the fact that you can't study everything. So there's a distinct possibility that in the exam, you may not actually remember features of copper deficiency. You might remember copper excess, that is Wilson. But still you can crack this question by the laws of exclusion. And I'll just highlight the salient features, the exclusion component that I highlighted. Option number A said lead poisoning. Well, basophilic stippling of RBCs, not visualized. We don't read about spinal cord involvement there. And in lead poisoning, you never read about combination lower motor, upper motor. Miller-Fisher syndrome, easy to rule out. Cranial nerve palsy, in this case, no cranial nerve palsy given. Devick's disease, yes, that could have been the error that could have occurred in a student's mind. Why? Because Devick's disease will also have a spinal cord involvement, and MRI spine is given. So you might be tempted to answer this, but then the point against Devick's disease is optic neuritis should always be present. I want you to understand that subacute combined demyelination can be having combo of lower motor and upper motor neuron lesion. In fact, I can now highlight 3 diseases that you should be aware of where combination of upper motor, lower motor is given. And these are the usual ones that is asked. One is subacute combined demyelination. Second is Friedreich ataxia. That's the one that is related to frataxin gene. And well, the third one where combination can be present is motor neuron disease, also referred as one of the variants as amyotrophic lateral sclerosis. The answer to this question is option number B. Was slightly a difficult one. In case you missed it, don't worry. I mean, everybody is in the same boat. There is obviously you're gonna miss some, but you're gonna get some correct. The next one is easier. A patient with the following peripheral smear will present with, well, in this case, what you can definitely notice is presence of flame cells. In fact, traditionally, flame cells would be present only in the bone marrow, but in this case, there's a possibility that the disease might have extensively spread and even come into peripheral circulation. So, one, I can say flame cells is what you read with multiple myeloma. Now, hand and foot syndrome is what is seen with sickle cell anemia. Black urine is a feature of intravascular hemolysis. Black urine can be seen in patients of G6PD deficiency. Black urine can be seen in falciparum malaria, that is black water fever. But per se, I cannot pick up any malarial parasite here. And I am not seeing any evidence of hemolysis also. The RBCs look almost normal in size. Then is elevated haptoglobin. Now, this can be easily ruled out. Why? Because I'm saying that haptoglobin usually becomes lesser in hemolytic anemias. We don't have elevated. It's either absent or it could be reduced, but definitely not elevated. Splenomegaly with gallstones. That is a feature of hereditary spherocytosis. But when it comes to hypercalcemia, I hope you remember the mnemonic CRAB that I've taught you for multiple myeloma, where C would stand for hypercalcemia, renal failure, anemia, and bony lytic lesions. The correct answer for this particular question would be option number D. You just had to pick up the flame cells present here and then work out that this could be a possible multiple myeloma and work out the feature that is hypercalcemia from the CRAB mnemonic. Question number 4 talks about an 8-year-old boy who's presented with the requirements of multiple blood transfusions. X-ray skull was performed. He says all are true but the condition shown except. So one, if you're gonna be having presentation of requirement of multiple transfusions plus you're gonna be having hair on end appearance, then the combination of the two will definitely point towards diagnosis of thalassemia. This is an except question. A says squaring of the metacarpals. You're aware that in thalassemia per se, there is expansion of the bone marrow. So when it comes to metacarpal bones, which might look like a dumbbell slightly because there would be a bone marrow expansion. As a result of it, it might actually change its shape and therefore the term used is squaring of metacarpal. So this is definitely a feature. Erythroid hyperplasia in the liver and spleen. You see, thalassemia per se is a condition where bone marrow is frustrated. So the responsibility of hematopoiesis would be given to liver and spleen. Both of them are working overtime, but there is no results because after all either beta chain is not there or alpha chain is not there. So they will definitely become compensatory changes in the bone marrow, and if the responsibility is occurring or is given to liver and spleen, even they will try to work more. So B looks like an okay statement. I'm just putting a plus minus to it, saying that it may be wrong, right? I mean, you can't be reading everything. Let's read C. Splenectomy, if transfusion requirement increases by 50% over last 1 year, I have already highlighted that whenever a person will have hypersplenism, you see the spleen has become bigger and then the appetite of the spleen will increase. This hypersplenism component will contribute to increase in transfusion dependency because the spleen is eating up the RBCs faster than what it should be doing. So this is definitely in. D says iron chelation leads to bronze diabetes. Let's read the statement again. Iron chelation is supposed to prevent bronze diabetes. It is not supposed to cause bronze diabetes in a patient. Option number D is grossly wrong. So I'll just put a double minus sign here to say that when you compare B versus D, the except question will have correct answer as option number delta. Iron chelation does not contribute to bronze diabetes. It actually prevents bronze diabetes. You see, bronze diabetes because in this case, there's gonna be a triad, no? I have highlighted this multiple times that there could be cirrhosis due to iron overload, there would be bronzing of the skin and type 1 diabetes mellitus as well. So the combination of these is what you read as bronze diabetes, and you can prevent this secondary hemochromatosis by using iron chelators. The answer to this question is option number D. In the next question, he has shown a child with acute lymphoblastic leukemia with a catheter, which I can casually call as a POTA cath. You can see just above the nipple of the child, you can notice that there is a port which would be definitely sending anti-cancer drugs directly into the bigger veins like subclavian vein. So what is the name of this catheter? Option A says Hickman catheter. Maybe right, maybe wrong. Malicot catheter. Malicot is what you read in surgery per se, like you have to do a suprapubic cystostomy. That is where you can use a Malicot catheter per se. So I'm ruling out option number B because that's what is usually used in surgery and not for delivery of any drugs. Seminobristia fistula. This is ruled out because we use it for hemodialysis. You see, in the kidney section, I've highlighted that we create a fistula between the radial artery and the cephalic vein, which is called a seminobristia fistula, and it's used actually for performing recurrent hemodialysis, which needs to be done 3 times per week, and it might be for 4 hour session usually. So a person with renal failure will have to spend approximately 12 hours per week in your hospital to get his blood cleaned of all the toxins. PICC is peripherally inserted central catheter. A PICC will be inserted from the cubital fossa and then would be going on. So if the image was of the cubital fossa, I would have thought definitely of a PICC, but because you can see the nipple of the patient, so it's definitely not a peripherally inserted central catheter. This is a Potacad delivering anti-cancer drugs directly. Subsequently, the drugs are directly reaching into the superior vena cava, reducing the incidence of thrombophlebitis associated with anti-cancer drugs. Therefore, the correct answer to this multiple choice question is option number A. It says the child which is having acute lymphoblastic leukemia is having a dash catheter. The answer is Hickman catheter. The next question talks about a patient started an R-CHOP regimen for non-Hodgkin's lymphoma, rituximab, cyclophosphamide, hydroxydonomycin, oncovin, and prednisolone. The investigation shown was done to monitor response to treatment. You see, per se, non-Hodgkin's lymphoma, there will always be a hematogenous dissemination of the cancer cells, and because of this dissemination, we will definitely have to do a test to identify which body organs are involved. Non-Hodgkin's lymphoma can spread to bone marrow. It's a cancer of the lymph nodes. It can spread to bone marrow. It can go to brain. It can go to liver. It can go to spleen. It can spread to every organ. He's saying what is the scan present here? You can see a contrast being concentrated in the bladder of the patient, also being excreted by the kidney. This is 18-fluorodeoxyglucose, no? You see, glucose is taken up by almost all the tissues in the body. So we are doing a test in which we are using radioactive glucose, because every time a cancer cell will go anywhere, the metabolic requirement of cancer cell is more, it will take up this radioactive glucose, will pick it up that the cancer cell is spread. The test is PET scan. The correct answer to this question is option number alpha. Actually, an image which was blurred came in the exam with respect to a PET scan that they could have just casually, if you take a film of a PET scan and just scan it using a routine scanner, the image might be blurred. So one student actually, he especially looked in Google for the Google images and found me this image, which was looking as if it's, drawn with on a paper with a pencil, the kind of light markings. But then you definitely can pick up a black spot that is bladder. You can pick up the contrast in the kidney, and because it's not a complete scan, so point is that he might have responded to the chemotherapy regimen. You see, per se, HIDA scan is done for conditions related to the liver, and in our case he was talking about a hematological malignancy, so I am ruling out possibility of HIDA scan being the answer. Muga scan is used to identify cardiac output. So suppose if I have to evaluate cardiac output in a post-myocardial infarction patient, Muga is multiple uptake gated acquisition scan. I repeat that again. Muga is multiple uptake gated acquisition scan. We use it for evaluation of cardiac output post-MI patients to see for whether there's a structural damage in the heart, to evaluate how the contractility of the heart is. So this is ruled out. So options are between PET and a bone scan only, and bone scan definitely can be ruled out because you're not seeing any bones in this case. You're seeing the soft tissues. You can see some outline of the pelvis. You can see some outline of the muscles of the thigh, but you definitely cannot see any bones in this case. So I think it's a touch and go in a sense, that straightforward question. PET scan is anyway used to evaluate distant metastasis. The next question says, which of the following is correct about the profile of a patient whose peripheral smear is shown below? If you look at this image, you will notice that there is some sky blue deposits inside the red blood cells. So the slide that we are talking about here is Prussian blue, right? And this Prussian blue is actually picking up some iron inside the red blood cell, which is definitely not normal. So we need to look at the options. He's saying which of the following is correct. So first of all, we need to be sure whether he's asking us to exclude the wrong thing or whether he's asking us to select one or more than one correct answers. I need to understand that if there is going to be iron present inside the RBCs in large amounts, then either it could be basophilic stippling of RBCs in lead poisoning, or he could be talking about sideroblastic anemia, because sideroblastic anemia again has RBCs loaded with iron. You see, Pappenheimer bodies is what I've taught you. In sideroblastic anemia, elevated serum iron. Yes, I mean, serum iron is definitely going to be elevated if Prussian blue is picking up inside the RBCs, right? Elevated serum ferritin. Yes, we have iron loaded red blood cells. The word is iron loaded red blood cells. So when you draw a sample, these iron loaded RBCs will definitely contribute to increase of serum ferritin. Low serum haptoglobin. I'm ruling that out because low serum haptoglobin is definitely a feature that you see with hemolysis per se. And in this question, evidence of hemolysis, at least in the slide, is not present. Low hepcidin activity. Well, hepcidin activity is usually affected by hemochromatosis. So, yeah, it could be a possibility, but most of the time in hemochromatosis, hepcidin activity will be increased. That is why more iron will tend to come in the body. So the correct options for this would be actually two of them, that is A and B. It is option number 1 which is correct for this. You need to understand that in some questions there might be too much information given, in some questions there might be scanty information given. Like here he basically started with you having the capability to analyze the slide. Well, what does this line represent? Either it could be a possibility of, as I highlighted, I mean, iron deposits inside the RBC could be seen with respect to lead poisoning, right? But then there was no choices related to lead poisoning per se, like urinary ala, or no mention regarding recurrent abdominal pain, peripheral neuropathy developing in a patient. So that is why I have thought this to be a possibility of sideroblastic anemia, and then I worked out the two correct options for this question. Moving to the next one, he's talked about a child on medical tourism to India. He's having anemia with hepatosplenomegaly and the peripheral smear is stained with a special stain. Well, RBCs are looking green, no? RBC is looking green, so we are talking about a supravital stain. And whenever I talk about a supravital stain, one of them that is always asked is crystal violet. And what are you seeing? You are seeing a lot of inclusions inside the red blood cell, which are giving the appearance of a golf ball. You see, the golf ball is obviously small, but at the moment it has a corrugated surface. If you see a golf ball, it has an irregular surface. So we are talking about golf ball red blood cells. And golf ball red blood cells is a start diagnosis that you encounter with hemoglobin H disease. Well, why is it not G6PD deficiency? Because G6PD deficiency will definitely have Heinz bodies. So yes, there is a possibility that even G6PD can be a diagnosis for this question. But then the point against G6PD deficiency in this case would be that Heinz bodies are very limited, right? You don't have such, like some of the RBCs are perfectly fine. That is one. Heinz bodies are bluish deposits which are usually present in the periphery of the red blood cell, whereas in this case it's a diffuse involvement. So yeah, this is definitely to be considered. Zika virus infection, well, will not be having anemia and organomegaly. Bernard-Soulier syndrome will have large platelets, whereas in this slide we are not seeing any large platelets or giant platelets per se. So two options can definitely be ruled out. It was just between G6PD and the golf ball cells that you had to pick up the information. And if you look at the slide of Heinz bodies per se along with white cells, that's slightly different from the way the current slide is looking. Along with that, clinical information will also help, no, because anemia with hepatosplenomegaly, that you usually read not with G6PD, you usually read that with HBH disease. That is a variant of alpha thalassemia. G6PD deficiency, guys, mainly will be having drug induced manifestations. Like if you are giving antimalarial drugs, you will be giving aspirin or nitrofurantoin. That is when you would be having this evidence of intravascular hemolysis, and the end result is even a possibility of acute tubular necrosis. So if the history given in this case was showing that some antimalarial drug was given to a child, even if it's medical tourism, doesn't matter. A child was brought to our country following administration of antimalarial drugs, then there's a black urine passed, and then there's a peripheral smear showing some limited bluish spots inside the red blood cells. Yeah, I could have considered G6PD deficiency in the possibility as well. In fact, a lot of guys casually, when they just look at the slide, they think that the spots here are those of Heinz bodies, and they tend to mark G6PD, but then you have to look at the question in the broader perspective. In the next one, he's saying which of the following findings are seen or shown in the peripheral smear. So you definitely can pick up target cells. That is not a problem. So I'm just putting a tick mark for that. Then it says an isocytosis, which means variation in the size of the red blood cells. So yes, I mean the shape per se is also varying and the size is also varying. So anisocytosis is very much present. I'm left between echinocyte and a nucleated red blood cell. See, echinocyte will always be having spikes on the surface of the RBC. In this particular case, RBCs are definitely distorted, but there are no spikes. Echinocyte per se will be having equidistant, E for echinocyte, E for equally distant spikes present on the red blood cell. So since there are no spikes visualized, this is unlikely to be present per se. And yeah, one of the arrows pointing towards what looks like a RBC with a blue dot inside. Initial casual look might actually make me think that I'm seeing a lymphocyte, but then lymphocyte will appear just basophilic. It will not have this bluish tinge around it. So this definitely looks like a nucleated red blood cell. So the correct options here are A, B, and C. And yeah, I understand that if you are casual in the options here, then you can definitely miss out is a nucleated red blood cell. The answer to this question is option number two. We move to the next one. Very classical. I mean, flower cells, right? Even if I don't read the question, I know the answer. A 22-year-old female presents with 2 weeks of fever, anemia, and a lymphadenopathy, hepatosplenomegaly, and skin rashes. So lots of things happening in the patient, and all these features are basically telling about that there is some hematological malignancy. TLC is grossly elevated. That's again highlighting a white blood cell disorder, probably a leukemia. Peripheral blood smear is shown anyway, and the immunophenotype is going to talk about a lot of B cell markers present, right? That's definitely going to tell you that we are talking about somewhere in the range of acute lymphoblastic leukemia. And then he's saying that the bone marrow aspirate shows lymphoblasts which are more than 20%. So everything is basically pointing towards presence of what we can call as adult T cell leukemia. Well, I want you to pick up this adult T cell leukemia not on the basis of flow cytometry, because you see there is definitely a T cell marker present here. That's going to be CD5. You see, then there's also going to be CD3. These are all T cell markers, basically TCR. So I want you to be able to pick up this adult T cell leukemia not on the basis of the flow cytometry report, but I want you to be able to pick up these flower cells. You can notice that the immature cells which are present here are either called as flower cells or called as clover leaf cells, because the nucleus will be having this irregular appearance, and the reason for this would be HTLV1. You see, initially he spoke about CD19, which is a B cell marker, but then specifically the T cell markers are given in this question. It is adult T cell leukemia which is caused by HTLV1. That is mainly to be remembered. And well, these are some details that I would like you to remember from the hematological perspective. In fact, if you study this topic of hemat in combination with pathology, your strike rate will definitely be increasing. So keep learning, keep hammering, guys. Thank you so much for your patience and hearing me out.